Hi, welcome to our channel of ignou audiobooks, Indira Gandhi National Open University, School of Social Sciences, SOSS, Master's Degree Programs, MA in Psychology, MAPC, Second Year, MPCE 0 to 1 Counseling Psychology, Block-4 Counseling for Mental Disorders, Unit-1 Depression, 1.0 Introduction. Most people at some point in their life experience at least some degree of low mood or depression. It is generally felt as sadness that is a normal response to painful circumstances such as financial losses, the breakup of a relationship, or losing a job. However, sometimes the depressed mood continues for a prolonged period of weeks or months. At this stage, a psychiatrist might diagnose a depressive disorder. Depression is a term used to describe a mood state in which the main symptoms or features include prolonged feelings of sadness or emptiness and lack of interest in previously enjoyed activities. This caused depressed people significant distress, since they lose motivation to participate fully in their lives. Depressed people have difficulty spending time with other people and might lose contact with friends and family, which could deprive them of essential support. They might even lose their job because of poor work performance or attendance. Depression can also result from medical conditions or other psychological disorders. For example, people suffering from adrenal and thyroid dysfunction display depressive symptoms due to their being either very over or underweight. Similarly, agoraphobics might become depressed because their fear of being vulnerable in public places makes it difficult for them to experience taking part in social activities. This prevents them from having essential, healthy contact with other people. In this unit, we will be dealing with depression, define and describe the symptoms, discuss the different types of depression, causes of depression, and then the treatment of this disorder. 1.1 Objectives. After completing this unit, you will be able to times define depression, times describe the symptoms of depression, times explain the causes of depression, times elucidate the different types of depression, and times describe the various treatment interventions for depression. 1.2 Definition and description of depression. Although depression is often thought of being in an extreme state of sadness, there is a vast difference between clinical depression and sadness. Sadness is a part of being human, a natural reaction to painful circumstances. All of us will experience sadness at some point in our lives. Depression, however, is a physical illness with many more symptoms than an unhappy mood. The person with clinical depression finds that there is not always a logical reason for his dark feelings. Exhortations from well-meaning friends and family for him to snap out of it provide only frustration, for he can no more snap out of it than a diabetic can will his pancreas to produce more insulin. Sadness is a transient feeling that passes as a person comes to terms with his troubles. Depression can linger for weeks, months, or even years. The sad person feels bad but continues to cope with living. A person with clinical depression may feel overwhelmed and hopeless. To clarify the differences between normal sadness and depression, there are specific, defined criteria for the diagnosis of major depression. A person who suffers from a major depressive disorder must either have a depressed mood or a loss of interest or pleasure in daily activities consistently for at least a 2-week period. This mood must represent a change from the person's normal mood and impair his functioning in his daily life. A depressed mood caused by substances such as drugs, alcohol, or medications is not considered a major depressive disorder, nor is one that is caused by a general medical condition. 1.2.1 Signs and symptoms of depression. General terms, times loss of interest in formerly pleasurable activities, times dissatisfaction with life, times withdrawal from social activities, times loss of energy, times feeling useless or hopeless, times irritability, times great concern with health problems, times sadness or crying, times worry and or self-criticism, times difficulty concentrating and or making decisions, times loss of appetite and weight. 1.2 psychological symptoms, feelings, thoughts and behaviors, times feeling sad, blue, depressed, or hopeless most of the day, times greatly reduced interest or pleasure in all or almost all activities, inability to think of anything that would be enjoyable to do, health permitting, times feelings of excessive guilt or a feeling that one is a worthless person, times slowed or agitated movements, not in response to pain or discomfort, times recurrent thoughts of dying or of ending one's own life, with or without a specific plan. 1.2.3 physical or somatic symptoms, times significant, unintentional weight loss and decrease in appetite, or less commonly weight gain and increased in appetite, times insomnia or excessive sleeping, times fatigue and loss of energy, times a diminished ability to think, concentrate, or make decisions, times physical symptoms of anxiety, including dry mouth, cramps, diarrhea, and sweating, ideation, or suicide attempt or plan. 1.2.4 criteria for formal diagnosis of major depression. The following criteria are taken from the DSM-4, the Diagnostic and Statistical Manual of Mental Disorders 4th edition, published by the American Psychiatric Association, 1994. For your convenience, a general listing of signs and symptoms of depression, the translated version, follows the formal diagnostic criteria for ease in interpreting the symptoms. For a diagnosis of a major depression, 1. At least 5 of the following symptoms. 2. These symptoms must be present during the same 2-week period. 3. These symptoms must represent a change from a previous level of functioning. Depressed mood nearly every day during most of the day. Times marked diminished interest or pleasure in almost all activities. Times significant weight loss when not dieting, weight gain, or a change in appetite. Times insomnia or hypersomnia. Excess sleep. Times psychomotor agitation or psychomotor retardation. Times fatigue or loss of energy. Times feelings of worthlessness or inappropriate guilt. Times impaired ability to concentrate or indecisiveness. Times recurrent thoughts of death, recurrent suicidal. Times someone who has major depressive disorder has experienced one or more major depressive episodes without ever experiencing a manic or hypomanic episode. 1. Major depressive episode. A major depressive episode is marked by either depressed mood or a loss of interest or pleasure in almost all activities and at least 4 additional symptoms from the following group. Times marked weight loss or gain when not dieting, constant sleeping problems, agitated or greatly slowed down behavior, fatigue, inability to think clearly, feelings of worthlessness, and frequent thoughts about death or suicide. These symptoms must last at least 2 weeks and represent change from the person's usual functioning. 2. Recurrent major depressive disorder. At least half of the people who experience a major depressive episode will later have a recurrence of major depression. For many people, an initial episode of major depression will develop over time into a recurrent illness. 3. Major depressive episode with psychotic features. About 15% of people with a major depression have some psychotic symptoms, usually delusions. The delusions typically include guilt, it is my fault that she is ill, punishment, I am suffering because I am a terrible person, or poverty, I will go bankrupt and starve in my old age. Sometimes, delusions do not have depressive themes. 1.2.5 criteria for dysthymic disorder. A. depressed mood for most of the day, for more days than not, as indicated either by subjective account or observation by others, for at least 2 years. In children and adolescents, mood can be irritable and duration must be at least 1 year. B. Presence, while depressed, of 2 or more of the following: 1. Poor appetite or overeating, 2. Insomnia or hypersomnia, 3. Low energy or fatigue, 4. Low self-esteem, 5. Poor concentration or difficulty making decisions, 6. Feelings of hopelessness. C. During the 2-year period, 1 year for children or adolescents, of the disturbance, the person has never been without the symptoms in criteria A and B for more than 2 months at a time. D. No major depressive episode has been present during the first 2 years of the disturbance, 1 year for children and adolescents, i.e., the disturbance is not better accounted for by chronic major depressive disorder or major depressive disorder in partial remission. E. There has never been a manic episode, a mixed episode, or a hypomanic episode, and criteria have never been met for cyclothymic disorder. F. The disturbance does not occur exclusively during the course of a chronic psychotic disorder, such as schizophrenia or delusional disorder. G. The symptoms are not due to the direct physiological effects of a substance, e.g., a drug of abuse, a medication, or a general medical condition, example, hypothyroidism. H. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Most people who have a dysthymic disorder would tell that they have felt depressed for many years or for as long as they remember. Feeling depressed seems normal to them. It has become a way of life. They feel helpless to change their lives. Dysthymic is defined as a condition characterized by mild and chronic depressive symptoms. Periods of dysthymia have been found to last from 2 to 20 or more years, with a median duration of about 5 years. About 3% of the general population and about 30% of those seen at outpatient clinics can be classified as dysthymic. Some researchers have criticized the DSM-4 criteria because they believe they do not give enough emphasis to what these researchers consider the most characteristic symptoms of dysthymia, the cognitive symptoms, including low self-esteem, feelings of guilt or thinking about the past, and subjective feelings of irritability or excessive anger. Because the depressed mood is long-lasting, dysthymia has sometimes been considered a personality disorder. However, most researchers include it in the group of mood disorders and believe it is biologically related to depression. Dysthymia and major depressive disorder have been found to have a high degree of comorbidity. This means that both types of mood disorders are likely to occur in the same individual. A person with dysthymic disorder develops symptoms of major depression because the criteria for both diagnoses are met. This dual state occurs quite frequently. Although dysthymia seems to make people more vulnerable to major depression, dysthymia itself is different from major depression in terms of the ages at which people are most likely to be affected. In major depression, rates increase in certain age groups, but in dysthymia, the rate is stable from about age 18 until at least age 64. Dysthymic disorders tend to be chronic, persisting for long periods. In contrast, periods of intense depression are usually described as time-limited, which means that even without treatment the symptoms naturally tend to lessen over time. 1.2.6 Criteria for bipolar I disorder. Most recent episode unspecified. A. Criteria, except for duration, are currently or most recently met for a manic, a hypomanic, a mixed, or a major depressive episode. B. There has previously been at least one manic episode or mixed episode. C. The mood symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The mood symptoms in criteria A and B are not better accounted for by schizoaffective disorder and are not superimposed on schizophrenia, schizophreniform disorder, delusional disorder, or psychotic disorder not otherwise specified. E. The mood symptoms in criteria A and B are not due to the direct physiological effects of a substance, example, a drug of abuse, a medication, or other treatment, or a general medical condition, example, hyperthyroidism. 1.2.7 Criteria for bipolar 2 disorder: A. Presence or history of one or more major depressive episodes. B. Presence or history of at least one hypomanic episode. C. There has never been a manic episode or a mixed episode. D. The mood symptoms in criteria A and B are not better accounted for by schizoaffective disorder and are not superimposed on schizophrenia, schizophreniform disorder, delusional disorder, or psychotic disorder not otherwise specified. E. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. 1.2.8 Criteria for cyclothymic disorder: A. For at least 2 years, the presence of numerous periods with hypomanic symptoms and numerous periods with depressive symptoms that do not meet criteria for a major depressive episode. Note: in children and adolescents, the duration must be at least 1 year. B. During the above 2-year period, 1 year in children and adolescents, the person has not been without the symptoms in criterion A for more than 2 months at a time. C. No major depressive episode, manic episode, or mixed episode has been present during the first 2 years of the disturbance. D. The symptoms in criterion A are not better accounted for by schizoaffective disorder and are not superimposed on schizophrenia, schizophreniform disorder, delusional disorder, or psychotic disorder not otherwise specified. E. The symptoms are not due to the direct physiological effects of a substance, example, a drug of abuse, a medication, or a general medical condition, example, hyperthyroidism. F. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. 1.3 Seasonal affective disorder: SAD. Sometimes people can experience depression at particular times of the year, especially in northern countries and typically in winter. This seasonal pattern to the depression is called SAD. People with SAD are often treated with light therapy, exposure to artificial lights that imitate daylight, to lift their depressive episode. 1.3.1 Typical symptoms: the typical emotions experienced during depression include sadness, guilt, and despair. It is also common for a depressed person to experience irritability, agitation, and anxiety. People suffering from depression can feel less motivated to participate in activities or interests they previously enjoyed. As the depression becomes worse, they might not bother to eat or cook for themselves, stop going to work or taking care of their appearance. Sometimes depression makes people not want to live and they might contemplate, attempt or even commit suicide. The effects of depression on a person's thinking include indecisiveness, reduced concentration and decreased speed of thought. People experiencing depression often have negative ideas, including self-criticism. They feel that others do not understand them or punishing them, and they do not look forward to the future. Depression can also cause changes in the sufferer's psychomotor activity. The changes can range from inactivity, psychomotor retardation, such as slowed movements or lack of movement, to restless activity, psychomotor agitation, such as pacing up and down. Depression causes a range of changes in physiological or body functioning such as reduced or increased appetite, fatigue or excessive tiredness, and loss of sex drive. Sleep disturbance is very common and has been estimated to affect more than 90% of depressed individuals. Depression can also cause shorter periods of sleep and increasingly broken sleep. DSM-4 outlines the criteria for a major depressive episode and also for the presence of a single episode of depression and recurrent episodes. For a major depressive disorder to be considered recurrent, a period of 2 months must separate each depressive episode. 1.4 Depressive disorders, unipolar disorders, 1.4.1 Dysthymic disorders. Most people who have a dysthymic disorder would tell that they have felt depressed for many years or for as long as they remember. Feeling depressed seems normal to them. It has become a way of life. They feel helpless to change their lives. Dysthymic is defined as a condition characterized by mild and chronic depressive symptoms. Periods of dysthymia have been found to last from 2 to 20 or more years, with a median duration of about 5 years. About 3% of the general population and about 30% of those seen at outpatient clinics can be classified as dysthymic. Some researchers have criticized the DSM-4 criteria because they believe they do not give enough emphasis to what these researchers consider the most characteristic symptoms of dysthymia. The cognitive symptoms, including low self-esteem, feelings of guilt or thinking about the past, and subjective feelings of irritability or excessive anger because the depressed mood is long-lasting. Dysthymia has sometimes been considered a personality disorder. However, most researchers include it in the group of mood disorders and believe it is biologically related to depression. Dysthymia and major depressive disorder have been found to have a high degree of comorbidity. This means that both types of mood disorders are likely to occur in the same individual. A person with dysthymic disorder develops symptoms of major depression because the criteria for both diagnoses are met. This dual state occurs quite frequently. Although dysthymia seems to make people more vulnerable to major depression, dysthymia itself is different from major depression in terms of the ages at which people are most likely to be affected. In major depression, rates increase in certain age groups, but in dysthymia, the rate is stable from about age 18 until at least age 64. Dysthymic disorders tend to be chronic, persisting for long periods. In contrast, periods of intense depression are usually described as time-limited, which means that even without treatment the symptoms naturally tend to lessen over time. 1.5 Causes of depression. Interpersonal and social factors that might affect the development of depression include social isolation and either separation from a partner or divorce. Biological factors that might influence the development of depression include changes in neurotransmitter levels within the brain. Neurotransmitters carry chemical messages between neurons and can influence mood and behavior. 3 types of neurotransmitters, serotonin, dopamine and norepinephrine, assist in the regulation of emotions including stress, sleep functions and appetite. All 3 are often found at lower levels in depressed people than in non-sufferers. 1.5.1 Genetic factors. Researches indicate that people are between 1.5 and 3 times more likely to develop depression if one of their parents or brothers or sisters has the disorder. Twin studies also have shown that if one identical twin develops depression, the chances of the other twin developing the disorder can be as high as 75%. This provides the evidence of the role of genetics in the development of the disorder. Researchers also considered the possibility that the combination of genes might be involved in the development of a vulnerability to depression, which increases a person's chances of developing depression. Vulnerability to depression does not mean that they will develop the disorder, but it means that they develop depression if other factors or situations also occur. Examples include growing up with parents who are overly critical or rejecting, losing friends or jobs, or being placed in stressful or traumatic situations. 1.5.2 Psychological factors. Factors which influence the possibility of developing depression include medical illnesses, traumatic experiences such as abuse, war or accidents, job stress, substance abuse, and the adjustment required following serious injury. Psychological theories of depression consider these factors as important in the development of the disorder. They focus on sufferers' subjective experiences and how they interpret the events that occur in their lives. The three main theories are psychoanalytic, interpersonal, and cognitive. 1.5.3 Psychoanalytical theories. Sigmund Freud suggested that depression occurs as a result of anger being turned inward, especially after the loss of a valued family member or friend. This loss can be either real, such as after the end of a relationship, or imagined, for example, people who feel that they will never be loved again. Freud stated that this internally directed anger leads to self-criticism and blame, and that the aim of this treatment is to release this anger. A consistent feature of major depression can be irritability, often directed toward family members or close friends. The criticism leveled against this view is that depression can affect people who have not suffered the loss of a loved one. Freud's theory that depressed people have internalized anger is also not supported by dream analysis research. Some of the latest psychoanalytic theories of depression have tried to address these limitations. They proposed that depression develops when people believe they have not reached their true potential, such as achieving good grades in school or gaining promotion or a pay raise at work. The effects of recognizing and accepting that they have not reached their expected goals affects their ego. The result is a general feeling of helplessness and low self-esteem that leads to depression. 1.5.4 Interpersonal theories. Theories suggest that depressed people have poorer social skills than people not experiencing depression. Social skills include the ability to relate to other people by making appropriate eye contact, being able to communicate clearly, being able to show empathy, and having a positive regard for others. People experiencing depression have also been observed to have poor problem-solving skills and make poor day-to-day decisions. It is also found that people who experience recurrent depression make poor decisions between depressive episodes. Depressed people are more likely to be rejected by their friends or peers as they have an aversive interpersonal style. 1.5.5 Cognitive theories. According to these theories, depression is caused by the misinterpretations or errors people make about themselves, their world, and the future. These errors are negatively focused. For example, sufferers might see themselves as useless, the world as uncaring, and the future as hopeless despite being successful in their jobs and having devoted families. Beck's cognitive triad. He observed that depressed people tend to make specific errors in their thinking, for example, deciding that they are stupid simply because they make one mistake in a test. He suggested that depressed people develop specific beliefs with strong negative elements based on these thought errors. A number of factors might lead to the development of these beliefs, including critical parents or rejection by friends, cognitive errors or biases in depression. 1. Arbitrary inference, drawing a conclusion from an event or situation when there is lack of evidence to support this conclusion. Situation: waiters in a restaurant forget to take your dinner order. Thought: they are ignoring me. I am obviously not worth their time. 2. black and white thinking, taking an extreme view of a situation, getting a test back and achieving 70%, thought, if I don't get 100%, I am a total failure. 3. Magnification minimization, exaggerating or ignoring a particular aspect of a situation. A woman finds out she hasn't been invited to a friend's party, thought, they obviously don't like me anymore. I must be a bad person. 4. Overgeneralization, a gross generalization based on a single event, situation, being unable to answer a question asked by a teacher, thought, I am going to fail the rest of the year. 1.5.6 Helplessness theories. These theories explore the specific thoughts of an individual when depressed. The concept of learned helplessness was demonstrated by Seligman. He believed that sufferers believe or find that they have little control over their lives and become passive. Theories also use the concept of attribution. Attribution refers to people's explanation of a particular event and their response to it. For example, depressed people might attribute failure to themselves when faced with a situation they have difficulty controlling, such as a difficult science test. 1.6 Treatment of depression. 1.6.1 Biologically based treatment. This approach includes antidepressant medication and electroconvulsive therapy. ECT. This approach is often successful in lessening depression. ECT is faster acting than antidepressant medication and is often used if an effective medication cannot be found. There are many types of treatment for depression, and some of the most frequently used include times antidepressant tablets, times mood stabilizing medications, times support with day-to-day matters while ill or recovering, treatments that are used less often but which can also be helpful especially in severe depression of a specific type or has proved difficult to treat include times electroconvulsive therapy, ECT, times special types of operation, psychosurgery, times bright light therapy for seasonal affective disorder, SAD. Lastly, there are potential treatments that are still either experimental or for which more evidence needs to be found before they can be considered truly effective and safe, times herbal remedies, e.g. St. John's wort, times transcranial magnetic stimulation, TMS, which involves applying brief, magnetic pulses to the brain. This is done with the patient awake and sitting in a chair. A doctor holds an electric coil near to the head that emits repeated, short magnetic pulses. The procedure is painless. At the present time, TMS is still under investigation as a treatment for depression. However, current evidence suggests that it may be as effective as ECT, but safer, broadly speaking. Treatments for depression can be broken down into two types. Firstly, there are those that aim to correct the chemical and biological abnormalities that occur in the illness. These are antidepressants, mood stabilizing medications, ECT and psychosurgery. Secondly, there are the psychological ones, talking treatments. These involve regular appointments to talk to a professional person who is skilled in a particular type of counseling or psychotherapy to help with depression. The biological and psychological treatments are certainly not mutually exclusive and are often used in combination. Neither group of treatments or therapies should be considered better than the other. The treatment or combination of treatments used should be the one most likely to help a person when all the different factors that have led to their illness are taken into account. This is the reason that approaching a professional is so important in deciding how best to cope with and treat depression. Antidepressant tablets. There are a number of different groups of these, and they include times tricyclic antidepressants, TCAs, e.g. amitriptyline, imipramine, lofpramine, times selective serotonin reuptake inhibitors, SSRIs, agfluoxetine, paroxetine, citalopram times monoamine oxidase inhibitors, MAOIs, agmoclobamide, phenazine, tranylcypromine times other medicines that do not quite fit neatly into these groups, but that have effects similar to one or more of these groups. For example, venlafaxine, mirtazapine, reboxetine, trazodone. The oldest antidepressants are the monoamine oxidase inhibitors, MAOIs, and tricyclic antidepressants, TCAs. The TCAs are still in wide use today and remain effective medicines. The MAOIs require a special diet to avoid unpleasant and potentially serious side effects, and they can interact with many other medicines. They are therefore generally used only for people whose depression has not responded to other treatments. The SSRIs are a much newer group of antidepressants, but they have been widely and successfully used for about 20 of years. All antidepressants work by boosting one or more chemicals called neurotransmitters in the nervous system. These chemicals may be present in insufficient amounts in depression, resulting in the symptoms of the illness. All antidepressants take a minimum of 2 weeks and sometimes up to 8 weeks to start to work, and once they have started working, the depression recovers gradually. It's vitally important, therefore, that if a person is given antidepressants, they should keep taking them regularly, even if they don't seem to make much difference to begin with. Some antidepressants can cause mild unpleasant effects if they are stopped very suddenly, but even these can normally be avoided if the medicine is tailed off over a period of time. A rule of thumb is that antidepressants should be taken for at least 6 months at the same dose after the person has recovered. This reduces the risk of the depression coming back again. A few people whose depression does return every time they come off antidepressants may need to be on treatment on a long-term basis. There is no evidence to suggest that any one antidepressant or antidepressant group is better than any other in terms of the number of people who will benefit from it. Generally, around 2/3 of people will find that their symptoms improve on any particular medication. But one may be a better choice than another on the grounds of its side effects. For instance, a person who finds that their sleep is disturbed may benefit from an antidepressant that is also quite sedative. By contrast, someone who is sleeping reasonably and has to be able to listen out for their children would clearly find this effect a problem and would be better with a non-sedative medication. If an antidepressant from one group does not work very well, then there is a good chance that one from another group may work. Mood stabilizers. In depression, these medicines are used to boost the effects of antidepressants. The best-known mood stabilizer is lithium. It is also the best proven one, but one drawback is that regular blood tests are needed to check its level. Lithium is also used in bipolar affective disorder, manic depression. There are some newer mood stabilizers available now that offer alternatives to lithium, such as sodium valproate, Epilim, or semisodium valproate, Depakote. Electroconvulsive therapy. Electroconvulsive therapy, ECT, is a treatment that has been used for many decades for depression. But it is controversial. The facts are, it is a very effective treatment for depression, perhaps the single most effective treatment. It is especially effective for severe depression and depression that has a lot of physical symptoms, such as changes in appetite, sleep and concentration. It is as safe as any minor procedure that needs a general anesthetic. It can be life-saving as it can work more quickly than antidepressant medicines. There's no good evidence for any permanent damage to the nervous system. Like all treatments, ECT does have some side effects. These can include times headache, times forgetfulness around the time of treatment. 1.6.2 Psychodynamic approach to treatment of depression. According to Freud, depressed person had a strong and punishing conscience, and the reason for it was to control anger and aggressive feelings that otherwise come forth to hurt others. Psychoanalytic theorists have suggested that clinical episodes of depression happen because the events that set off the depression revive dimly conscious, threatening views of the self and others that are based on childhood experience. Bowlby also believed that childhood experiences that contribute to these depressed feelings were not single events but developed from long-term patterns of familial reaction. This approach helps the client to become aware of their beliefs that originated in childhood. The therapist facilitates the process of transference so that the client exhibits all his reactions that were suppressed. The therapist helps the client to identify his reactions and help him in alter these reactions. 1.6.3 Interpersonal psychotherapy. It focuses on teaching people to be more socially effective as a way to improve their relationships with their significant others. It integrates the psychodynamic perspective, which emphasizes early childhood experiences, with the cognitive behavioral perspective, which emphasizes current psychosocial stressors such as chronic marital discord. This therapy works well when paired with the use of antidepressant medications and has been demonstrated to be effective both in lessening depressive symptoms and in extending the period of remission for individuals who have a history of recurrent depressions. 1.6.4 Behavioral therapy. As depressed people lack skills necessary to develop satisfying relationships with others, one behavioral approach to this problem is through social skills training. Social skills training consists of several parts. First, clients are taught basic verbal and nonverbal skills. When these are learned, the clients practice gradually putting the basics together. Then clients are given homework, assignments in which the goal is to adapt the new skill so it is useful in the everyday environment. Clients are also trained to be more perceptive about cues other people in the environment give, and they learn how to change their own behavior in response. Finally, clients learn to adopt realistic criteria for evaluating their performance and are taught how to be self-reinforcing. Role play is necessary so that the client gets the practice needed to use new behaviors in the real-life situations. The practice gained from these assignments is in turn critical for success in learning new habits. 1.6.5 Cognitive behavioral therapy. This therapy makes use of both behavioral and cognitive theoretical perspectives based on the client's skills, degree of depression, and on the chosen goals of therapy. The main focus of CBT is to help clients think more adaptively and, as a result, to experience positive changes in mood, motivation, and behavior. The more severely depressed the client, the more likely the therapist is to use behavioral techniques at the beginning of the treatment process. Clients are taught how to self-monitor their experiences, noting which gave pleasure and feelings of mastery and which lowered their mood. They are also taught to monitor and record their negative thoughts. Special emphasis is put on automatic thoughts, recurring thoughts that come into a person's mind almost as if by habit rather than as a specific response to what is currently going on. Therapists use several techniques to help clients identify these thoughts, including direct questioning, asking the client to use imagery to evoke the thoughts, or eliciting them by means of a role-play situation. The clients are also asked to keep a daily record of their thoughts. The record includes notes on the situation, emotions, automatic thoughts, and the outcome. In this way, the client learns that a person's view of reality can be quite different from the reality itself. The therapy can help change dysfunctional thinking and thus alleviate the depression by challenging parts of the client's belief system. 1.7 Summary. The term depression is commonly used to refer to normal feelings experienced after significant loss such as the breakup of a relationship or the failure to attain a significant goal. These feelings are not classified as a depressive disorder by DSM-4. Symptoms of grief over the death of a loved one also are not classified as depression unless they continue for an unusually long period. Depression can refer to a symptom or disorder. The symptom of depressed mood does not necessarily mean a person has a depressive disorder. Some symptoms of depression occur frequently in people who have the blues but are not clinically depressed. But those who meet DSM-4 criteria experience symptoms that are more severe. Depressive disorders include dysthymic disorder and major depressive disorder. Depression is the result of an interaction between biological characteristics, psychological vulnerabilities, and stressful events or ongoing stressful life situations. Treatment to depression includes biological, psychodynamic, interpersonal, behavioral, and cognitive behavioral approaches. Thank you. Subscribe to our channel for more updates. And we will see you with the next chapter.